Okay, good afternoon. Good afternoon. Welcome to the Assembly Committee on Health and Human Services. Would the Secretary please call the roll?
Assemblywoman Gonzalez.
Here.
Assemblywoman Gorlow. Assemblyman Gray. Assemblyman Hafen. Here. Assemblyman Hibbets. Assemblyman Koenig. Here. Assemblywoman Newby. Here. Assemblyman Nguyen. Here. Assemblywoman Taylor. Assemblywoman Thomas. Chair Peters. Assemblyman Orenlicker.
Here. Okay, if we may be joined by one or more members, so please mark them as present when they arrive. But it appears we have a quorum, so we have one bill hearing. It's all yours, Jay. Assembly Bill 117. So this is on Medicaid coverage for the services of community health workers. So when you're ready, I have some housekeeping things. First, please silence your electronic devices, phones, laptops, etc. And I'm sure we have other housekeeping. Members of the public may provide testimony in various ways, all of which are listed on the agenda. You may also submit public comments in writing, either in addition to testifying or in lieu thereof. Written public comments may be submitted before, during, or up to 24 hours after adjournment. If you wish to testify in person, please sign at the table by the door and leave a business card. We don't have Zoom. Please when you come up to testify, please turn the microphone on when you're speaking. And don't forget to introduce yourself and spell your name for the record. And I think that's all we need. So we'll open on Senate Bill 117, as I say, for community health workers. It looks like we have Jay Colbert-Clausell and Sarah Adler. Will you be co-presenting? Okay, would you like to begin?
Thank you, Mr. Acting Chairman and members of the committee. I will begin today. I am Sarah Adler, and I'm with you today as Sarah Adler, who is a longtime board member and former board president of the Healthy Communities Coalition of Lyon and Story County. And we at HCC are proud to host the Nevada Community Health Worker Association, as we have for several years. And so SB 117 and community health workers are kind of like today, a sunny Friday afternoon. They are a good thing. And we at HCC have had the opportunity to help bring the experience of community health workers throughout Nevada. I will let Jay Colbert-Clausell, the program manager, speak in detail, but I just want to let you know, my personal background is having worked for many years in rural Nevada, having worked in education, and having worked as a volunteer a great deal in mental health. And community health workers are a win in all of those contexts. We have educated Jay's organization and his partner trainers have community health worker graduates from every single county in our state, including 5 in Esmeralda County. And they work actively in multiple fields, including education and in mental health. And what CHWs do is they bring lived experience and of the community cultural context to supporting and connecting the work of professionals to their clients. And the last thing I would like to say is that we have experienced over these years of working with CHW, being a CHW is a career building opportunity. It's past employment, it's a career building opportunity. I was listening to testimony on, I forget which of our several hundred bills have been working in this building, but I was listening to testimony from a woman in Las Vegas who's previously incarcerated, and the way that she stated that she should have the right to whatever this bill was offering was to say, I am a community health worker. That is the reframing that this profession has offered to her and to more than 1,000 other people. So with that, I will turn it to Jay to present more information on CHWs and the bill.
Thank you, Chair Ornlicker. This is Jay Colbert-Clausel for the record. It's good to see you all today. This bill was brought forth by the interim health or human, oh, sorry. You get nervous every time, but the HHS committee. And it's 3 years in the making. So many people have contributed to what this bill could be. And Nevada really moved cautiously, bringing AB 191 in the last session and having community health workers compensated by Medicaid in chronic disease prevention and management. And that's just gone so well. And then this bill comes and brings us in alignment with the other states. So we have these little pictures here because CHWs bridge. They are more communication. They talk. They have that connection to the community. They bring security, and they bring health. So the roles of CHWs are summarized in these 13 competencies. So I won't read all of them here, but there is a national movement to kind of self-align and standardize and make the field consistent across the various states without it being like a formal process. So as a social worker, we have a national association that does accreditation. Within CHWs, that's not how it works. Each state gets to assign and grow as they see fit. Texas was the first to officially recognize CHWs 30 years ago. And so Nevada is a little late to this one. But now we are a leader. We're being contacted for support in how we have launched our CHW program from AB 191. And we're providing technical assistance to Kansas and to other states that want to do this same work and really work with the CMS federal system to get approval for CHWs who can extend the reach of the licensed professionals, have more time with clients, and save funds for both the states and those medical facilities. Some of the other states have this similar language where the supervisors for CHWs are licensed providers. And so without getting into too many of the details, I think a few of them that are worth highlighting is in New Mexico. They prohibit CHWs from doing the work of a licensed professional. And we also do that here in Nevada because CHWs are not a replacement for licensed professionals. They're an extension of what licensed professionals do and keeping those referrals going and helping people to actually achieve the case plan that's been written by a licensed professional. And then we did our program through a state plan amendment. And we had several state plan amendments, which in December also included the tribal clinics. And so that was a really amazing win for the CHRs, which are very similar to CHWs. So CHWs are a community, anyone can be a community health worker. We have kids that go out and advocate for the health of the community and their parents. They might help with translation. But in Nevada, we have certification through the Nevada Certification Board. The people who have agreed to certification have completed the initial 8-week core training, and then they've also signed a code of ethics, and they've committed to continuing education every 2 years that's submitted. And we find that really important for that career development, that growth, and that quality care that our CHWs are going and they're having a continued commitment to learning. This certification board also does certified prevention specialists, the birth doula certification, and peer recovery support specialists and the support specialist supervisors. This is the code of ethics that the CHWs sign. So you can see across, we're really defining what the CHW does and what commitments they are making to the community. One thing I meant to cover a little bit earlier is I just ran some statistics on who has graduated in the last 12 months. So of the 325 students who finished our CHW core program, 26% are African American, 29% are rural, 9% are Native American, 37% are Hispanic or Latino, 2% from Pacific Islander communities, 4% Asian. And we've had students from every county even in the last 12 months. these are the people that we want to bring into the healthcare system. Right now, we have a diversity problem, both of all types in our healthcare. And we want a door, an open place for the community members to participate in the healthcare system. And this is really it. These are the other training programs in the state. So TMCC accepts students at any time. So if you have somebody who needs to apply for their CHW now, they're the best group to contact, and they can do that program online. Our program is on quarters. The College of Southern Nevada has an in-person and a hybrid program. CASAT, many peer support specialists and those in recovery also do CHW training. And then High Sierra AHEC does training for CHWs, and they can start the career and get right into the healthcare pipeline right in high school. For the amended bill text, we're really looking at saving Nevada money and increasing the quality of care. Section 1 was removed because the language just didn't align with the original goal. Section 2 is really the goal of this program, which is to align our supervision requirement with the other states so that we can bill or we can do state plan amendments with CMS and have more CHW services in more settings across the state. Right now, only physicians, physician assistant, APRNs can supervise those CHWs. This expands it to licensed professionals who have then been approved by CMS. And then that final item, Medicaid reimbursement must be under the supervision of an NRS-defined provider of healthcare. This is my contact information, and I have some references on CHW work, and then references on supervision. And we're really looking at beefing up how we do supervision in Nevada and maybe even creating a credential for supervisors, especially those who might not already have a medical license that could potentially be a good task supervisor for a CHW in the future. And with that, I'll open it up for questions. Thank you.
Thank you very much. Questions from Assemblyman Koenig, please.
So I'm in the the healthcare field, but I don't have a grasp on this here. So first question is, what is the education/training that they have to do to become certified? How long is it? What classes? Just a basic overview of what education they would need?
Yeah, J. Colbert Classell for the record. It's an 8-week program that focuses on professional skills, some basic assessment. So they can't do an assessment that a licensed professional would do. But CHWs are often the first contact with a community member. They might be in a food pantry, or it might be somebody who steps into an emergency room. So like at the Renown program, they find that if a CHW is the first person to talk to the person, that helps the hospital deploy their resources more effectively. So that, because the CHW might be able to take care of small things and immediate referrals, where if you have the doctor come in the room first, they're caring people, and they often will spend time when there might be a higher needs situation down the hall. So CHWs do about 8 weeks of training, and their job descriptions should reflect that. This is not an associate's degree. This isn't a 2,000-hour internship for most CHWs. It's just knowledge about how to communicate with the licensed professionals, how to do referrals, how to understand the social determinants of health, and then how to advocate for often the communities that those CHWs are from.
Follow up, if I may. So now they're working under the license of physicians, PAs. There's a couple other things there. So is the PA or is your physician going to be billing Medicaid for their work? They're not billing Medicaid themselves. They're not under their own, they don't have their own numbers and so that they wouldn't be billing for what they do. They would be employed by the physician, and the physician would be billing Medicaid for what they do.
J. Colbert Classell for the record. So that is how it is done currently when billing Medicaid. There is a provider type, 89 for CHWs, but it's under the NPI number of the licensed professional. And so the billing does go through that licensed professional's enrollment with Medicaid.
One last one, please. So when I bill Medicaid for what I do, I mean, you got a booklet and your procedures, what you've done, that's how much you can bill Medicaid for. I mean, how much are they gonna bill for I talked to them before the doctor saw them? I mean, what's the CPT code? Is there a pricing set out where if they talk about this, you can bill this much, or is it an hourly thing? Or how does the specifics of them billing for their services? I mean, I don't believe there's CPT codes that exist for that at this point. I mean, all of that have to be created, or give me an idea how that would look.
So J. Colbert Classell, for the record, we do have a current program that's operating. There are 3 codes, and it depends on the number of clients who are being served. So if a CHW is doing a blood pressure self-management class for 8 people, the reimbursement's near $100 per hour. If they're working with one individual, it's in half-hour increments, and I think it's close to $16. Of course, it's Medicaid, so things can be more complicated. So in a tribal clinic, it's billed at the encounter rate, as long as it's done on a different day that the service is provided to the doctor. And the reason why the federal government approves that is they found just better outcomes, fewer emergency room visits, and so it's worth it to bring in those CHWs and have that additional 12 hours maximum per month that's allotted.
That gives me a better picture. Thank you, Vice Chair.
Sure. Assemblywoman Thomas.
Good afternoon, and thank you, Vice Chair, and thank you for the presentation. My question actually has to do with, and I know that this isn't a fiscal, but I would like just to know, on average, what is a salary for the CHW?
J. Colbert Classell, for the record, through you, Chair.
You may go directly to the member.
Oh, thank you. So the salaries often range from $14 to $30 per hour. So there's a wide range. It's going to depend on what that specific CHW is qualified to do and what services they're providing. So a CHW that's very organized and can do lots of classes and bill Medicaid for those classes could be reimbursed at a higher rate. Through our grant funding, it can depend on the setting. So we have CHWs who are within the justice system, and so it's kind of a different system, different setup of grants. So it's hard to compare across the entire institution of CHWs. In a medical setting, you're going to see a higher rate in the 20s.
Assemblywoman Taylor.
Thank you, Mr. Vice Chair, and thank you for bringing the legislation. I appreciate it. Just a question about how many CHWs that work in the medical. You just mentioned that some of them do it in the legal side as well, but about how many people do you think this will impact?
So J. Colbert Classell, for the record, we are currently at 20% are in medical. We'd like to see some growth with that. We have a lot of CHWs in the schools who are doing like resource type work, and we're also trying to help them understand a little bit of the medical side too, so they can refer those families where they need to be.
You said 20% of...
20% of the CHWs.
Do we have any idea how many? Do we have a number?
Of CHW?
Yes.
Oh yeah, J. Colbert Classell, for the record, that's about 400, if
Okay.
I'm doing the math right, who are currently in medical.
Okay.
If I may, Sarah Adler, to add to that information, since 2015, 1,796 individuals have signed up for a CHW training course. And we have a 65% completion rate so far. 11,175 have completed. And something I wanted to add, Jay, if I may, is that the profession itself is developing. Right now, you take your introductory CHW training and there is no exit exam. As we know, exams seem to be high stakes and are difficult for some people. But there is now a CHW2 classification, and that does require an exit exam. So even within this field, the profession is developing, and to Assemblywoman Thomas's point, part of that structure is to enable people to move up to higher income levels.
Pardon me, Jay Colbert Classell for the record. Just one small change. We haven't launched the exam yet. That's the goal for CHW2. For CHW1, a high school graduation is not even required. Now, we would help anyone who becomes a CHW in any medical setting is going to require a high school equivalency, but the certification itself is just that 8-week training, signing the code of ethics, and committing to continuing education.
Thank you. May I follow up, please?
Yes, you may.
Thank you very much. So in that, then, because you're talking about, you said maybe the higher level of training, would you think perhaps in that those that are in the medical that fill the role, or do you think they're at the higher end of the hourly? Do you think for them, like you said, it can be anywhere from $14 an hour to $30 an hour. Where do the medical CHWs fall generally, or is there? And there's probably a difference between the 1 and the 2 as well, I would imagine.
Jay Colbert Classell for the record. So there's CHW1s and CHW2s can both bill Medicaid, and that isn't, or there isn't a specific type. It's all market driven, I guess. That's what I'm sharing there. Our highest paid CHWs are training. So those are the CHWs who are training other CHWs and elevating their skills.
Okay, so, but they can't bill Medicaid, right? They go through the doctor, right? As my colleague asked.
Yeah, Jay Colbert Classell for the record, they're grant funded. So our organization has 7 current grants for CHW funding. We actually are now, I get to announce today the 40 recipients of a Southern Nevada CHW scholarship of $4,800. So some pretty amazing opportunities out there to reduce those barriers and help elevate those skills for CHWs.
I appreciate that. Thank you very much.
Assemblyman Nguyen.
Thank you, Mr. Vice Chair. Thank you, Mr. Adler and friend here for your presentation. Just following up to a lot of my colleagues, the same line of questioning in terms of the future of this profession. And what I really liked to hear is that these folks really are the champion for these minority communities or community with language barriers in terms of navigating this so complex system, right? Are we seeing across the country, and I apologize if I missed that in your presentation, as far as licensing steps in the future, just because if there are technical requirements, there are some advanced knowledge, and then as well as some language capability, right? We want to make sure that things don't get lost in translation or things get confused, and then obviously the patient end of the deal will be at a disadvantage, right? Has there been any efforts across the country, if you will, of going towards some sort of licensing aspects of this particular profession?
Jay Colbert Classell for the record. So I think the term licensing implies a much higher level of training and experience. And so we've actually pushed back against a license. We have some grants that do a 2,000-hour internship for a CHW. These new 40 students will be doing that. But that isn't appropriate for most CHWs. I mean, we have students who are 98 years old, and they just want to be able to engage their community and their school and be a little bit more knowledgeable about health. And so at that level, that's what's happening. Now, nationally, we have the C3 project where we are self-aligning towards that, where that certification and that training is all in alignment. Our program was developed in collaboration with the state of Massachusetts and the state of Washington. So we got both sides there, and that's the curriculum that we use in Nevada through DPBH, and it was developed 10 years ago.
Quick follow-up, Vice Chair. Thank you. So in terms of the liability that this could be raised in terms of that issues itself, so the liability of the CHW action or inaction, would that be absorbed by the license provider that they are under, so to speak? Is that, and I think that's why I'm looking at or asking about the licensing piece, is because it has some safeguard, right? Some guardrails and safeguards in there on what the consequences of either action or inaction from these folks. And I know the purpose is there to help, right? But just want to make sure that in situation where folks can be misinformed or folks are inaccurately informed, that where do we kind of follow up with if that community health worker is unable to perform a certain task or given the wrong information or the incorrect information, then does that fall back on the provider? Does that fall back on a body that could investigate these circumstances or situation?
So J. Colbert Classell for the record. Complaints can be submitted to the Nevada Certification Board to investigate. And currently, we can only bill Medicaid for a CHW service if they have that certification through the Nevada Certification Board. Ultimately, the liability does fall on that licensed professional, and so they want to hire people they trust and who are going to listen and share accurate information. Overall, we have CHWs in such a broad number of settings that I still don't think a license would be appropriate in all of those settings.
Thank you for the education. Appreciate it.
Seeing no further questions, thank you for the presentation and answering the questions. And that will now move to testimony. If there's anybody here who would like to testify in support of some Senate Bill 117, looks like we have Jimmy Lau. Please introduce yourself and spell your name.
Good afternoon, Vice Chair Orentlicker, members of the committee. My name is Jimmy Lau, first name J-I-M-M-Y, last name Lau, L-A-U, with Ferrari Reader Public Affairs, representing Dignity Health St. Rose Dominican. St. Rose has employed CHWs for more than a decade down in Southern Nevada and was an early adopter of the model because they recognized the benefits that CHWs had on improving outcomes. Just last year, St. Rose implemented a new program down in Southern Nevada called the Pathways Community Hub, which coordinates CHW services across all of those different fields, medical, employment, into a single stream to assist people who need those types of services. And this Pathways model has been implemented in several states across the country. And the savings that are realized through it are pretty phenomenal. I jotted down a couple. One of them is Chicago, where they saw an average savings of $5.58 per every dollar spent on a CHW, and Baltimore, which realized about $80,000 to $90,000 per year per CHW employed. So St. Rose looks forward to being able to expand its Pathways program down in Southern Nevada with the passage of this bill and urges the committee's support, and I'm happy to answer any questions. Thank you.
Thank you for your testimony. Anybody else here in Carson City who would like to testify in support? Is there anybody in Las Vegas? If you want to testify, please come to the table. Doesn't look like it. Broadcasting, do we have anybody on the phone line?
To testify in support of Senate Bill 117, please press star 9 now to take your place in the queue.
Hello, good afternoon, Chair and members of the committee. My name is Catherine Nielsen. I'm the Executive Director of the Nevada Governor's Council on Developmental Disabilities. I'll try to be brief today. We have a community health worker who is on our staff and who serves as our public health liaison. Her primary responsibilities include gathering information on the impact of the pandemic for the access and functional needs population. And this population encompasses those who may have language access needs, those with disabilities, and those who have any sort of access or a functional need during an emergency, where her goal is to improve outcomes for future public health emergencies and to ensure those with access and functional needs have less of a negative impact next time, because there will be a next time. And this model will ensure that the quality of community health workers in this community is continued in all areas of public health. And I thank you for your time today.
Thank you for your testimony. Next, online or on the phones broadcasting, please.
Hi, good afternoon, Vice Chair Orntlicker and the committee. My name is Steve Messenger, Messinger. I'm with the Nevada Primary Care Association, representing the state's federally qualified health centers. Our health centers serve more than 100,000 Nevadans, the vast majority of which have incomes below 200% of the federal poverty level, and about a quarter of which take their patient care in languages other than English. And community health workers are so important to the work that we do. We are community health centers. We're designed to be connected to the communities that we serve, and we serve the most underserved Nevadans. And I want to just hit a couple points. I think that Jade gave a great presentation, but this bill is the evolution of more than a decade of investment in community health workers in Nevada. Nevada famously has gaps in our healthcare system. And about 10 years ago, the state realized that one of the best ways to bridge those gaps and to take patients from the lack of access that they have or the lack of connection that they have in their communities to where they need to be and where they can get care in a language that they understand, in a communication style that they can understand, that's sensitive to the communities that they actually live in. The community health workers were the best investment to do that. And so I just encourage the committee to please pass this bill. It is really the silver bullet that we have. You aren't going to invest enough money to fix the other health disparities in Nevada, and this is sort of the low-hanging fruit of what we can do. And that's what I want this committee to understand. Thank you very much.
Thank you very much. Next caller, please.
If you have recently joined and want to testify in support of Senate Bill 117, please press star 9 now to take your place in the queue. Caller with the last digits 820, please press star 6 to unmute your phone.
Hi, good afternoon. My name is Andrea Gregg. I'm the Chief Executive Officer for High Sierra AHEC. I'm here representing AHEC in addition to our Nevada Healthcare Workforce and Pipeline Development Work Group. We are calling in today to highly support Senate Bill 117. As a training provider for community health workers, we are seeing boots on the ground the success of the way in which we can utilize community health workers and the way in which they can really help mobilize a significant effort to support, certainly those in rural and underserved areas. So I just would like to put on record today on the behalf of AHEC and the work group to have you highly consider this bill. It is a thought, innovative bill that can really start to lead our state in the right direction on where we know we're falling significantly short from a provider perspective, an access perspective, as well as a health equity perspective. Thank you.
Thank you very much. Next caller, please.
Vice Chair, there are no callers to testify in support at this time.
Thank you, Broadcasting. We'll now move to opposition testimony. Is there anybody here in Carson City or in Las Vegas who would like to testify in opposition? Doesn't look like it. How about Broadcasting? Is there anybody on the phone line to testify in opposition?
Vice Chair, there are no callers to testify at this time.
Okay, then we'll move to neutral testimony. Anybody here in Carson City or Las Vegas who would like to testify in neutral? Okay. Anybody in the phone line?
Vice Chair, there are no callers to testify at the time.
Okay, thank you. That concludes our testimony. Would you like to close? Either you, Jay or Sarah?
J. Colbert Classell for the record. No, thank you for your time today.
Well, thank you very much. We'll close our hearing. That's our only bill, so we'll now turn to public comment. If you would like to make public comments, anybody here in Carson City or Las Vegas who would like to make public comment today, that means not on the bill we heard, but on any other aspect of health and human services. Okay. Broadcasting, do we have anybody in the phone line?
Vice Chair, the public line is open and working, but there are no callers at this time.
Okay, any comments from members? Well, thank you for your participation. We can adjourn now, and we will reconvene Wednesday, May 3rd at 1:30, I believe. So thank you. Have a good weekend.